welcome to Let's Talk Dental, a BIOLA's webinar series. We're very excited to welcome Dr. Paul Chang as our speaker. The lecture this evening is titled Predictable Extraction and Immediate Implant Replacement with the Aid of an All-Tissue Laser. We are hosting tonight's webinar on the Zoom platform, and we do welcome your questions during the lecture in the Q&A feature in the lower toolbar of your screen. Now, I was just speaking with Dr. Chang, and he's got a lot of fantastic content to show you this evening. So we may or may not have a few minutes at the end to address questions. If we do run out of time, we will give you information on how you can reach BIOLA's education or how you can rewatch a recorded version of this webinar. This is the first webinar in our new Let's Talk Dental series. We have several more webinars scheduled and planned to kick off 2024, ranging in topics from frenectomies for infants and adolescents to billing and coding tips. You can find more information about these webinars at our BIOLA's education website. That's education.biolase.com. At the conclusion of the lecture and the Q&A session, I will provide information about BIOLA's education CE process, so you do get a CEU for joining us this evening, along with additional web resources you can access to continue your learning journey in laser dentistry, including upcoming in-person courses you may want to consider. Tonight's webinar is being recorded and will be posted, as I mentioned, to our webinar library in the coming days. And again, our education website is education.biolase.com. So with that, let me formally introduce our speaker. Dr. Paul Chang attended Baltimore College of Dentistry in Maryland, where he earned his doctorate of dental surgery in 2003. He then completed an extensive 5-year residency program at the University of Texas Health Science Center at San Antonio, where he was awarded specialty certificates in both periodontics and prosthodontics. While in San Antonio, he also completed his research on biomodification of titanium surfaces to improve initial implant stability and earned his master's degree in the School of Biological Science. Less than a year after completing his residency program, he successfully challenged both the American Board of Periodontology and American Board of Prosthodontics board examinations, and he is one of only a few dual board certified dental specialists in both periodontics and prosthodontics in the United States. Dr. Chang currently maintains his specialty practice in beautiful McKinney, Texas. So Dr. Chang, again, thank you so much for joining us this evening, and I will pass it on to you, good sir.
Great. Thank you, Joe. Like Joe said, I am board certified in both periodontics and prosthodontics. I have been in private practice for almost 15 years now. My main focus nowadays are dental implants in aesthetic zone and managing dental implant complications. I want to mention here that while I do receive an honorarium to give this presentation, but be aware that I will not speak on a product if I don't believe in it. To teach, it is my way to give back to the profession that has changed my life. With that said, let's talk about implants. Since Professor Bennemark placed the first implant in an edentulous mandible some 50 years ago, dental implant has become the standard of the care. Dental implant restoration provide superior aesthetics, function compared to traditional prosthesis. Not to mention study after study have found overall success rate of 95% or higher. Based on iData research, there has been about 15 million implants placed in the United States from 2017 to 2021 alone. And that number is projected to grow by 7 to 10% each year. So as a general dentist, if you have not started placing implants in straightforward cases, then you are falling behind the curve. Implant placement and loading protocols have changed quite a bit since Bennemark days. Instead of waiting 6 months after tooth extraction, we now wait 3 months, or attempt to place the implant at the time of extraction. If implant is in the aesthetic zone, an immediate provisional restoration is often attached to the implant as well. So what criteria do we look for in a successful implant restoration? Clinically, a healthy implant does not have marginal inflammation or BOP or suppuration. In general, probing depth should be less than 6 millimeters. There should be a presence of adequate keratinized tissue to protect the underlying mucosa. Radiographically, with the platform switched internal connection implants, we should expect to see we should expect the bone at the crest or coronal to the implant platform. How long should we expect an implant restoration to last? That's a tricky question nowadays, isn't it? We used to say that once you get an implant, it will last you a lifetime. Does anyone still tell their patient that? If you look at the survival rate published in journals, overall, it is about 95% successful, no matter who, when, where it was published. However, the success rate of dental implant in real world is much lower, as noted by De Silva in articles. The survival rate is really only about 82% at 5 years. If we look specifically at peri-implantitis, which is bone loss plus gingival inflammation, studies have shown that at 5 years, around 12% of implants will develop peri-implantitis. When we get close to 10 years, it increases to 45%, almost half. So when patient asks you, "Doc, how long will my implant last?" How do you answer it? Well, based on my clinical experience, implant will last 3 to 5 years if it is poorly restored, poorly placed, and without proper maintenance. 5 to 7 years if implant is placed ideally but poorly restored and without proper maintenance. More than 10 years if implant is placed ideally, restored ideally, and the patient has kept up with proper maintenance. In general, implant complications can be divided into 2 categories. Early complication, which is failure to integrate due to systemic issues, surgical errors, and insufficient bone quantity or quality. And late complication, which occurs after implant has been osseointegrated. These include ill-fitting restorations, biomechanical overload, and ineffective maintenance. One thing for certain is that any complications, whether it's early or late, will lead to peri-implant mucositis and peri-implantitis. So today, I'm going to focus on how to prevent early complication with proper surgical protocol and augmentation techniques. Okay. Successful, long-lasting implant restoration starts with proper extraction and preservation. For dentists who just started placing implants, I highly recommend you review the past principles described by Homley and Lakshmi in 2006. To quickly summarize it here, passive, tension-free wound closure using a barrier membrane such as a collagen or EPTFE to help exclude unwanted cells and stabilize the blood clot. Complete granulation removal to ensure that the bone graft is in direct contact with healthy bleeding socket wall. Intramural penetration, aka cortical penetration, to create regional acceleratory bone regeneration. Stabilize the wound with bioactive membranes such as amnion chorion and PRF membrane, and the use of non-wicking monofilament sutures. Let's look at this case. Tooth number 8 was extracted and socket grafted 3 months ago. This is the PA, post-op, 3-month post-op PA. What do you see here? What about now? Is this patient ready for implant placement? No, because periapical granulation tissue was not completely removed before graft material is placed. So now we have to gonna remove the granulation tissue and the grafting material, regraft the area, start all over. Okay, let's look at another case. Tooth number 30, endoperial lesion. Tooth was removed and grafted. This is immediate post-op. This is 3-month CBCT. Do you like what you see? Again, these cases stress the importance of complete granulation tissue removal to prevent it from competing with bone cells in regenerating socket. Now let's talk about how do we properly degranulate and disinfect the extraction socket. In general, we use mechanical method, which are spoon curettes and burrs. What is the problem with curettes and burrs? Well, sometimes the curettes are too big to reach all the way down to the apex for complete granulation tissue removal. Also remember, mechanical method cannot kill the live bacteria remaining in the extraction socket. So when you're scraping the socket wall with your curette, you're actually pushing bacterial smear layer into the bone. This is confirmed by Nelson's study in 2010. He found 69% of the extraction site had the presence of bacteria after mechanical debridement and saline rinse. 21% of healed site still tested positive for bacterial presence at the time of implant placement. So mechanical debridement alone is insufficient. What about adding chemical treatment? Do any of you guys use chlorhexidine, hydrogen peroxide, or ozonated water to irrigate the extraction socket? What is the problem with chemicals? Well, chemical solution is not only toxic to the bacteria, but also the healthy cells needed to help bone and soft tissue to regenerate. According to Liu's research, chemical solutions such as chlorhexidine permanently halted cell migration and reduced the number of cells needed for new bone formation. What about placing antibiotics in the socket or with your bone graft? As shown in Kim's study, placing antibiotics in the socket or mixing it with bone graft material will cause cellular necrosis and growth inhibition compared to saline-soaked group. Antibiotics prevents infection, but also results in poor regeneration and slow wound healing. So what other tools do we have? Well, a YSGG all tissue laser. It can not only remove the granulation tissue, but it can also kill the bacteria that's embedded in the extraction wall. In my opinion, the best socket disinfection and granulation tissue removal method is the combination of surgical curettes and a YSGG laser. The way YSGG laser works is by superheating the cytoplasm inside of the bacterial cell, which is mostly liquid, causing vaporization and membrane to burst. YSGG laser can also help us accomplish another key pass principle, that is angiogenesis, by providing sufficient blood supply for bone regeneration. We know the surface layer of the extraction socket is made up of what? Cortical bone. The cortical bone is highly mineralized and it has very little regenerative capability. It can actually act as a temporary hindrance for the access of desirable cells and tissue components from the marrow space because resorption of the cortical bone has to take place first. By performing intramedullary, also known as decortication of the extraction socket wall prior to the bone graft, it provides communication with marrow space, which enhances revascularization and allow growth factors such as platelet-derived growth factor, bone morphogenic protein to be released into the socket, thus enhance bone regeneration. If you look at the Mish's article in 1999, he found that when he performed decortication on the buccal and lingual wall of the extraction socket and then place the bone graft, bone healing is enhanced 2 to 10 times higher than normal. So extraction site decontamination and preparation is especially important in cases like this, where the tooth has had endodontic treatment and there's a chronic periapical lesion. If bacteria and granulation tissues are left behind, your graft result will be less predictable. So in my practice, I will first use surgical curette and round burrs to remove the bulk of the granulation tissue, followed by my YSGG all tissue laser to remove the granulation tissue that's left behind by the curette and kill any bacteria that is still embedded in the socket wall. In addition, I will use my YSGG laser to decorticate the socket wall to improve what? Blood flow and promote bone regeneration, as you can see here. After using YSGG laser to decontaminate and decorticate the socket wall, I then proceed with bone graft. By adhering to the past principles, we can preserve the alveolar ridge predictably and thus make future implant surgery a slam dunk. Here's another case. You can see the defect left by the perioendo lesion following extraction. I was able to completely regenerate the extraction socket, thus making implant placement more ideal. This is a vertical root fracture case. Tooth was extracted and graft followed by the YSGG laser decontamination and decortication. Implant placed in conjunction with osteotome 3 months post extraction. Now patient is ready for restoration. Very predictable. So what about cases like this that have severe bone loss? We know there will be significant bone loss and missing one or more socket walls following the extraction. Again, we will follow the past principles. In addition to complete removal of the granulation tissue and intramural penetration to increase blood flow, I will add barrier membrane and bone that is space maintaining to reconstruct the defect. Passive tension-free closure. After bioactive protective membrane has been placed over the bone graft material, this enabled the wound to heal with less reepithelialization and wound contraction, thus make the bone regeneration more predictable. As you can see here, over 90% of the defect has been reconstructed or regenerated. So now let's add immediate implant placement to the mix. We still need to follow the past principle. However, now we also need to add atraumatic tooth extraction, precise implant placement, and primary implant stability to the mix. In this case, I extracted the tooth atraumatically to preserve the socket wall, decontaminated and disinfected the socket wall using my YSGG laser, and also performed cortical penetration using the YSGG laser to allow bone regenerating mesenchymal cells to reach the socket from the base faster. Implant was then placed in a restoratively sound position, grafted, and a barrier membrane placed over the top. 3 months later, patient is ready for restoration. Okay. Now, here's another case. Tooth was extracted while preserving the socket wall. Socket was decontaminated, decorticated with the YSGG laser. For this case, the critical factor is whether I can achieve primary stability or not. If I cannot achieve primary implant stability, then implant placement is aborted and socket preservation will be performed instead. Here is 3 months post-op and implant restoration attached. Once you get comfortable with immediate implant surgeries, you can also add sinus lift to the mix. In this case, I removed the fractured root while preserving socket wall, performed socket decontamination and decortication with my YSGG laser. Sinus lift was performed using osteotome technique, followed by immediate implant placement. Implant was then allowed to heal for 4 months before final restoration is attached. Here's another case. I just treated last week. Extraction, immediate implant, and osteotome sinus lift. What I'm trying to show you here is I don't document 1 or 2 cases to the nth degree and then go out there to lecture on them. I have been doing these kind of procedures day in and day out with long-term success to back it up. So let's look at another case. Again, it's done just in November. You see the gutter aperture remaining at the extraction socket. Again, I was able to use my YSGG laser to blast it without removing the excess bone at the apex. Because otherwise, if I remove too much bone, I would not be able to place the immediate implant. So now let's raise the level of difficulties even higher. Let's talk about immediate implant and immediate load in the anterior aesthetic zone. This protocol requires experience and is very technique sensitive. I would recommend you do not attempt it until you are comfortable with posterior immediate implant first. In addition to everything we have discussed previously, we now have to add what? Preservation and augmentation of both hard and soft tissue, precise implant placement, achieve primary implant stability, fabricate quality temporary restoration that supports the soft tissue, and proper occlusion. Okay, so we have to add a lot more factors. One of the key factors to remember for placing implants in the anterior aesthetic zone is that if there's insufficient bone volume, do not place the implant. Augment it first. This patient came to me for a consult. I told him he needed a lateral ridge aug before implant can be placed. He didn't like what I had to say, so he disappeared. A year later, he came back and asked for my help. What can we do now? Nothing. What do you see here? That is pink composite on the exposed root as a result of poor implant surgery. Let's not even get me started on the poor implant placement. Which brings me to the second key factor is don't place the implant too shallow or too deep. This implant is placed way too apically. What kind of results do you think she will get? Not a pretty one. Once you get to this stage, it is too late. There's not much we can do. So let me show you how I would do it in my office with this case. Tooth number 9 is experiencing external-internal resorption. Step number 1, I used my YSGG laser to decontaminate the sulcus and to separate the PDL from the root. I use it as a periotome. Okay. Tooth was removed atraumatically. I then used the surgical curette to remove the bulk of the granulation tissue. After that, I used my laser to decontaminate the extraction socket. Okay, remove any remaining granulation tissue that is embedded all the way down to the apex. Here, I then performed intramural penetration with my YSGG laser. As you can see, with a thin, long tip like that, I can decorticate all the way down to the apex. Anywhere I can reach with a probe, I can use my laser to get to it. Okay, implant is then placed in an ideal position with sufficient primary stability. I then grafted the gap between the implant and socket wall. Provisional restoration fabricated, occlusion checked, Here is at 1 month post-op. Notice the black triangle between 8 and 9. Now at 3 month post-op. Notice the preservation of the facial wall. That is the critical factor we need in the anterior aesthetic zone, is preservation of the facial wall. Here, temporary crown was removed, digital impression was taken, custom abutment torqued in, and final restoration attached. Here's before and after. So now let's increase the level of difficulties even more. This patient came in with hopeless teeth, number 8 and number 9. Endo lesion were present at the apex of both teeth. CBCT was taken to evaluate cross-section thickness of the alveolar bone. What is your treatment plan here? Extraction, bone graft, immediate implant, single tooth, both teeth. What is your protocol? My treatment was to extract number 8, place an immediate implant, and fabricate a immediate provisional, if possible, for number 8 first, because of the draining fistula at the number 8. And also study have shown that if we extract both centrals at the same time, we run the risk of losing interseptal bone, which will result in the loss of interdental papilla between 8 and 9. So I choose to do one at a time. Tooth number 8 was atraumatically removed, immediate implant placed, bone graft performed, and then fabricated a immediate provisional and then attached it and checked the occlusion. Patient is allowed to heal for 3 months. Now I'm ready to proceed with immediate implant number 9. Let me show you how I do it step by step. First, I use my YSGG laser again to decontaminate the sulcus and separate the PDL fiber. Next, I will remove the tooth while preserving the soft tissue and the facial wall. Make sure you don't damage the papilla and make sure you protect the facial bone. Next, I use my surgical curette to remove the bulk of granulation tissue. Okay. Followed with YSGG laser to decontaminate the extraction socket. As you can see here, I'm doing a sweeping motion, basically trace the entire extraction socket wall to remove any residual granulation tissue that is left on the extraction socket. Okay. After that, I will go ahead and decorticate the extraction socket as well. Okay. Again, when we decorticate the extraction socket, we promote angiogenesis. Once the extraction socket was found to be intact, now I will proceed with my implant placement. Remember, ideal implant placement is critical for aesthetic restorations. Don't go too deep, don't go too shallow, don't place it too palatal, and don't place it too facial. Okay, it's very, very critical you place the implant in a 3-dimensional manner. Also remember, you need to graft the gap between the implant and the socket wall to help protect and preserve the facial plate. If primary implant stability is achieved, then I will proceed with my immediate provisional restoration fabrication. Okay, remember to check your occlusion. Let's look at here, pre-op, the picture on the left. The picture on the right is 2 weeks post-op on implant number 9, 3 month post-op for implant number 8. Here is 3 month post-op for number 9, 6 month post-op for number 8. Temporary crown and temporary abutment was removed and scanned for final restoration. Here is final abutment torqued in place. Temporary crown cemented. What do you guys think? Notice the tiny black triangle between 8 and 9. Even after I went through all of the procedures and steps to preserve the papilla, we still had a little bit of loss of interdental papilla. Will it get better? How do we know that? Is if you preserve the interseptal bone, the papilla will come back. Okay, remember the Tarnell's study, the distance between the contact to the crestal bone. Okay, so this is 6 weeks later. If you take your time to preserve the interseptal bone, and then the papilla will grow back, will stay, even between 2 implants. Here is before, and here's after comparison. Okay, it is a complete life-changing event for this patient. This is why I love about our profession. We can change somebody's smile. Okay, so to summarize what I've discussed so far, the key to predictable immediate implant surgery is atraumatic extraction site decontamination and decortication using YSGG laser, precise implant placement, and ideally fabricated provisional restoration to support soft tissue during healing. If you follow these principles, even difficult cases, such as this one, becomes manageable. In this case, I can confidently tell the patient that her implants will last at least 10 years or more because I know the implants are placed ideally, it is restored ideally, and the patient is keeping up with her oral hygiene. I'm going to use the last few minutes to review different types of lasers because there are a lot of misconceptions regarding laser in dentistry. What you see here are all the lasers that is available in dentistry. Do they all work the same? No, they don't. There are huge differences between them. So I'm going to spend a couple of minutes here. Laser generally are grouped by the type of medium it is used to generate the laser beam. Different medium generate different laser wavelengths, which have vastly different tissue interactions. Dental laser can also be grouped by the type of tissue interaction. So on the left, what we have is called soft tissue only laser. They're non-surgical. And on the right, we have all tissue laser. So what that means is they can work on soft tissue and hard tissue. Okay? So what makes them different is how the energy is being absorbed. If you look on the left, the laser can only work on soft tissue. Why? Because they're being absorbed by the pigments and hemoglobin. And then on the right, we have all tissue laser is because their energy is being absorbed by water and hydroxyapatite. Where do we have water? We have water in soft tissue. We have the water in bone. We have the water in enamel, root, everywhere. Hydroxyapatite is all present in the hard tissue. Okay. So soft tissue laser are ideal in managing periodontal disease. Why? Because their laser energy selectively target the pigmented bacteria that causes periodontal disease and the inflamed erythematous periodontal tissue. So when soft tissue laser, such as diode or Nd:YAG, is used in conjunction with scalene root planing, what we typically see is faster healing and more noticeable reduction in bleeding on probing at the follow-up appointments. Okay, so it does not remove bacteria or calculus, but it will help decontaminate the diseased pocket and reduce inflammation. So what about an all tissue laser? How do they work? Well, all tissue laser energy is preferentially absorbed by what? Water and hydroxyapatite. Where do we have water and hydroxyapatite? Again, everywhere in our body. All tissue laser, especially a YSGG laser, is very efficient in cutting the soft tissue because the high level of water content that is present in the gum. Whereas soft tissue only laser, in order to perform any kind of soft tissue surgery, what do we have to do? We have to initialize the tip, which turns the tip into a what? Hot knife. So when you are performing a frenectomy, gingivectomy using a soft tissue laser, such as any kind of diode or an ND-YAG, you are basically burning the tissue with heat. You're not cutting with the laser beam nor the laser energy. You're using heat to cut. So yes, it does not cause any bleeding. It's really good at hemostasis, but also you are creating a huge zone of necrotic tissue, which slows down the healing and increase post-operative sensitivity. So here, I want to show you a side-by-side comparison on a lingual frenectomy performed using a soft tissue laser versus a all tissue laser on the right. Okay, as you can see on the left, they're using a soft tissue laser. In order to minimize the excessive charring and burning of the tissue, like I showed you what it did in the previous video, they have to slow down significantly. They have to turn down the power and increase the hertz. What does that do? That slows down the procedure. Look on the right. I can use my YSGG laser to cut and cauterize the tissue at the same time without sacrificing speed or worry about bleeding. So I'm already done on the right side. They barely started on the left. Okay, let's not wait for them. So when you compare efficiency and speed, all tissue lasers are way better at performing soft tissue surgeries than soft tissue only lasers. Okay, soft tissue lasers are what? Diode and ND-YAG. All tissue lasers are what? Erbium, chromium, YSGG laser, erbium YAG, and CO2, specifically 9300 nanometers. So let's find out why I picked erbium, chromium, YSGG laser over other all-tissue lasers. One of the reasons is hemostasis and coagulation ability of the YSGG laser. When we look at thermal penetrations of different lasers, if you look at the soft tissue laser, which is diode, ND-YAG, and the CO2 10,600 nanometers, they penetrate deep into the soft tissue and cause excessive thermal damage, like I showed you before. Once we remove those three, the only ones left are erbium, chromium YSGG, erbium YAG, and the CO2 laser. Those are the three that does not penetrate so deep in the tissue that can cause tissue necrosis. So now let's compare specifically the erbium, chromium YSGG versus erbium YAG laser. If you look at this graph, you'll notice the erbium, chromium YSGG laser penetrates 300% deeper into the water-containing tissues than the erbium YAG. Okay, so people say, why does that matter? Well, it is the ability to achieve sufficient hemostasis without sacrificing speed doing surgery. Erbium, chromium YSGG laser penetrates deeper in the tissue, as you can see here. It cuts through the tissue efficiently and has the ability to cauterize the small blood vessels along the way. As you can see here, I'm going through some of the blood vessels and it's not even bleeding, right? Versus if you're using a erbium YAG laser, the energy is mainly absorbed by the water on the tissue surface. Why does that matter? That's because then if energy is absorbed on the surface, then there's minimal hemostasis. So after a frenectomy like this, what you will see is a significantly more bleeding with erbium YAG than the erbium chromium YSGG laser. Look on the left, YSGG laser. Look on the right, which is the erbium YAG laser. Okay. So lastly is ergonomics. Erbium YAG and CO2 lasers uses articulated arm delivery system. This results in very bad ergonomics. Imagine doing surgeries for 2 hours sitting like that. Versus BioLase erbium chromium YSGG laser chose to use a trunk fiber rather than articulated arm for their laser delivery system. So this makes much easier to perform surgery to reach areas that is very difficult to get to, such as posterior teeth, as you see when I'm working here. On the left, I'm using a erbium YAG laser. The articulating arm is in my way. I really cannot see the in between the molars, versus with a trunk fiber, I have much better visualization of the defect. Now let's look at the size of the handpieces. Imagine holding one of these for 2 hours. Which one will produce more strain on your wrist? So when we look at the efficiency in cutting, hemostasis, hemostasis capability, and ergonomics, erbium YAG laser wins. And this is why I use it every day in all of my surgical procedures. There are many other uses with erbium chromium YSGG laser that I really didn't get a chance to talk about in them because of the time constraint. For those of you who are interested in learning more about YSGG laser complications and management of dental implant complications, you can follow me on Instagram at ifixdentalimplants. BioLase website also has a huge library of free on-demand webinars for those who want to learn more about YSGG laser. I've attached a QR code for the link for those of you who are interested. I want to thank you all for spending the last hour with me. Joe, I'll let you take it.
Yes, sir. Thank you so much, Dr. Chang. We did have a few questions posted, and to our audience, if there are any other questions out there, be happy to address those before we wrap up tonight's session with Dr. Chang. Dr. Chang, there were, I think, 3 questions as you were going through your beautiful cases that were around your laser settings that you use. So you just went through, you prefer the erbium chromium YSGG, that's the waterlase laser. Maybe spend just a minute or two going through the settings that you prefer when you're in decontaminating the socket and decorticating, and how you use the laser with the settings.
Yes. So this is another benefit of having a BioLase laser, because they have a graphic interface which has the degranulation and decortication setting already pre-programmed into the laser. So if you're just starting, I will use their default setting. You can start with that. With that said, with the laser, there are many factors that can affect the speed, the efficiency of the laser. Not only just the power. Okay, we have the power, we have the hertz, we have the water, we have the air, we also have your hand speed movement, we also have the distance between your laser tip and the tissue. So just by telling you the laser is not gonna, the setting for the laser is not gonna be sufficient. I just want you to know that there's really, BioLase has done a really good job of giving you guys some hands-on courses, and they have their brand new facility that can actually show you how to optimize your speed and efficiency. But back to answer to your question, what are the settings? So if I'm degranulating soft tissue, typically I am at 2 watts, 30 hertz, with 60 water, 40 air. If I'm at decorticating the socket wall, I will increase my power setting to 2.5 to 3.0. Depends on how thick the cortical plate is. So some of the cortical plate is, if it's very thick, then you have to increase the power.
Perfect. Thank you for addressing that. We had another question come in. Dr. Mason Miner. Hey, Dr. Miner. When you decorticate the socket, how deep of a hole do you make?
How deep? There's the how deep and how many. So nowadays, when I decorticate the extraction socket, I don't just puncture 1 or 2 holes. I'm almost resurfacing the entire socket wall with my laser first, and then I'll start poking holes. The holes are, I use an MZ6 tip. My socket wall, when I'm done, it looks like a honeycomb. How deep do you go? You want to at least get through your cortical plate. So what you're gonna do, we say in Texas, when you shoot somebody, what do? You double tap. So same thing here. You want to do at least go back, go into the same spot at least twice, maybe 3 times, so that you can actually penetrate through the cortical plate. You are actually going to feel that you're dropping into the marrow space. You want to actually penetrate into the marrow space.
Perfect. And I just wanted to make sure I got your settings that you discussed a second ago, Dr. Chang, is 2 watts, 30 hertz. And what were the air and water settings?
Yeah, so 2 to 2.5 for granulation tissue removal, 30 hertz, 60, 40. For decortication is 2.5 to 3.0.
Got it. Perfect. Thank you for that. I just posted that in the chat for our audience to write down for Dr. Chang's settings. That does help us segue a little bit to some of the closing information I wanted to review with the audience. If there are any other questions that you would like to post, feel free. We did get one other question, Dr. Chang. S or H? I'm guessing it's is it S or H mode?
Oh, it's always H mode. Always.
Yeah, that's what I almost said. I'm guessing it's H mode, but I didn't want to say that.
Yeah.
And then
If you're doing surgery,
me.
if we're doing any kind of periodontal surgery, we're always in the H mode.
Yeah. Okay, great. Thank you for addressing that. To our audience, as we wrap up here, again, if you go to education.biolays.com, I'm sure that's where some of you found the registration site for this webinar this evening. It also has really nice video content in there, clinical animation videos, case videos. You can sign up for courses, you can sign up for future webinars, and you can watch recorded webinars at this website. If you go to biolays.com, there is an education link at the top of the page in the main menu. That's another way that you can find the education site. And if you're posting a couple more questions, I'll get back to those. I'm going to review some information about how you can get your CEU here.
Oh, Joe.
Yes.
You can tell them that, we're having a advanced perio training for the general dentist. I think is coming up at the new facility later this year too, right? So
you're right. You're teeing me up.
Yeah. So they can learn a lot about this with other, managing peri-implantitis, managing periodontal disease, managing immediate implant site preservation. Those, I'll be talking about a lot of those during that one-day
Exactly.
course. Yeah.
Yep, exactly. So if you, to our audience, if you go to the Waterlays Academy tab on our education website, then this is the course that Dr. Chang just mentioned. So Dr. Chang is one of our lead instructors at BioLays Education on the perio side of our education. And you can come and take his course at our brand new state-of-the-art facility in Foothill Ranch, California. It's on March 22nd. It's a full-day course. And you can find the registration link of this course at our education website, education.biolays.com. If you have any questions about the specifics of the course, The registration page has all of the learning objectives and the course description in there. And then if you have questions past that, you can definitely reach out to our education team and we'll help answer those for you. A few of the others that we have, we do have a slew of courses lined up for the first quarter of 2024. Dr. Chang's is on March 22nd, but we do have a couple courses in February as well. We have an advanced mastery course that's focused on advanced settings and restorative applications of the Waterlase, erbium, chromium, YSGG in early February. We also have a foundations course. So for our current users, if you have a business partner and an associate that has never been formally trained, that's a great course for you to attend. If you are interested in purchasing a laser, that's the first course that we would put you into to get the foundational content down. And then on the endo side, we do have an advanced course focused on endodontics in Dallas coming up in February as well. And we'll keep you posted on future courses that we line up. We do have a fun event focused on frenectomies and tongue ties in the Miami area, tequila and tongue ties on April 19th through 20th, 2024. We try to behave ourselves at this event, but I did want to let you know it's coming up in April. We have an early bird discount on registrations with this conference. It's a day-and-a-half conference, and that early bird discount ends at the end of January. We have information about this on our education website as well, or you can go to tequilaandtongueties.com. As I mentioned, you can go to our virtual education area of our website to look at on-demand webinars and live, sign up for future live webinars. Give us about a day, maybe 2 days, and we'll have this webinar edited and up on our on-demand webinar library for you to rewatch if you would like to do that. And then these are the other webinars we have lined up. Dr. Chang took on the first webinar of the year, but we have 2 coming up on February 15th and then in early March focused on frenectomies. We have a myofunctional therapy webinar coming up on March 21st, and then we end the quarter, the first 3 months of the year, on March 28th with a billing and coding webinar. So if you have staff members, office managers that you want to get on that webinar to learn how to properly code for procedures, that's a good one to hop on. Okay, we will wrap up. So again, you do get a CEU for joining us. You must be officially registered. Attendance will be recorded via Zoom. There's going to be a survey email that goes out to you, our audience members. Fill out that survey and you will get your CEU after you complete that. Please check your spam, your trash, all of your folders. Make sure you get that survey after we wrap up. And when you complete it, you'll get that CEU. Any other questions or inquiries, feel free to email our education team here at BioLase at education@biolase.com. With that, Happy New Year to everyone who joined us. Dr. Chang, thank you for the work that you did in your presentation and all the beautiful cases that you showed us. We appreciate your knowledge and your expertise. And to our audience, thank you for joining us, and I hope you have a wonderful rest of your week. Take care.
Thank you.